Welcome to this webinar on introduction to mental health, specifically anxiety disorders. This is a short session to give you some idea of what anxiety disorders are, more specifically to hopefully debunk some myths as well. Just give me a minute, I'm gonna just mute. Is hopefully to debunk some myths about anxiety and whether it's normal to experience it or whether it's not. I think some of you would have prior knowledge about anxiety issues, but maybe not so much of the specific clinical knowledge. On the same note, this is not going to be like a full-bloom lecture on what anxiety disorders are. In fact, I would like to pique your interest so that you might go on to read more about the topic and hopefully develop some interest along the way. Right. So towards the end, I have a little piece of a book, or rather ebook that I can share with all of you, and that's my perhaps early Christmas present for you to read. Right? Since young, we were always told to read, and so we should continue to do that as we move along. Right. So without further ado, let's go. I'll probably take about 45 minutes to cover my content. Might be a little bit speedy at some parts in the interest of time. And also there will be about a 15 minutes Q&A at the end. And of course, with almost about 60 to 70 of you in here, there could be a lot of questions, but we can only have time for a few questions. So we hope you don't mind. Mainly it is just to share some information with you on the topic. Just a little bit about me. You can address me as Anil. No need for Mr. Anil, no need sir and all that. I think my first name is fine. I'm currently an associate lecturer and an academic coach. So I do lecturing at various institutions, both public as well as private institutions. And I'm also a coach, academic coach at the Singapore University of Social Sciences, as well as private clients who have academic barriers. And my training is in both psychology and sociology. And I have an ACTA cert, which allows me to do WSQ training. And I also have a qualification in professional counseling. So that's just a little bit about me. Previously, I was in the rehabilitation sector for about 8 years. And I work very closely with ex-drug offenders as well as their family members. For the past 3-4 years, I've decided to do something that keeps me happy, and that's lecturing and coaching. And so I've been away from the rehab field for, say, about maybe 5 years. So I believe a lot has changed, and I would definitely consider a move back, because addictions on its own is a fascinating area of study. Right? So in terms of my work experience, I have dealt with offenders, both abusers and non-abusers, those who are guilty of penal offenses, so that means they're not drug consumers, and also students. So I think these are the two set of clientele that I deal a lot with, right? And definitely the issue of anxiety is something that I come across very frequently, but we need to really debunk what anxiety and anxiety disorders mean. So let's get down to it. So anxiety, I put here anxiety normal. So these are instances where if you get anxious, please don't jump the gun and say that, I think you have an anxiety disorder. We sometimes tend to self-diagnose, and we tend to diagnose other people. It does have an indirect impact in the overall stigma around mental health and disorders. Right? So I think we should try to move away from that. Instead, maybe we can try to find out a little bit more. Oh, you mentioned you are anxious. So how does your anxiety play out? Maybe we can suspend ourselves that little bit to ask some important questions. And these questions might, in fact, help us to find out a bit more about what the person is going through. Now, I think it's fundamental because if you do not ask some important questions, perhaps, and you don't know, you might wrongly diagnose the person, or you might refer them to some help when they actually don't need the help. And that could have some implications for them. So when is anxiety normal? Essentially, if you define it, it's a sensation of worry, nervousness, feeling uneasy, such as the feeling you get before, say, a final exam, a big presentation at work, maybe the uncertainties of the pandemic and whether the government is going to lift the restrictions if you are running a chain of restaurants, for instance. Did I have a little bit of anxiety before the session started? A little bit. I was thinking that, oh dear, it's going to be a lot of people, but then it's just a number, right? It's just affecting me a little bit, and of course I then need to do something to see how I can manage that sensation of worry. So I think this is normal. You feel some stress, but a good anxiety can motivate you to prepare ahead. So in view that I might face a little bit of this anxiety, I ensured that I rehearsed my presentation about 2 or 3 times so as to ensure that I deliver it within the time frame. Now, when whatever has been causing you to worry is over, you stop worrying and don't carry the anxiety with you. That's fine. So if I'm going to end off at 8, maybe, take a rest. 15 minutes later, I kind of completely forget about this session. Right? But maybe tomorrow, have a bit of debrief with my team and so on what more can be done. And then I'll think about it. If not, it's just going to be out. I think this is fine. So you don't carry the anxiety, you don't carry the worry forward to the next few days. So if some of your friends or family members say that, hey, I'm very worried about something, please understand them. Please know that the anxiety and the worries are part and parcel, and different people experience them very differently. So instead of being stigmatizing and, trying to say that, hey, why you always worry? A bit, you're so worried. You are a timid, scaredy cat, be a man or be someone who's brave. What's there to be worried about? We tend to trivialize the worries that people may have. Let them worry. If they don't carry the worry with them, that's fine. Now, when is it an issue? So here we put anxiety to be disorder. So if a person starts to experience physical discomforts, such as physiologically, fast heartbeat, giddiness, shortness of breath, and then this is not due to the mask, right? Sometimes we get shortness of breath because we wear a mask, but in this case, the mask is not affecting you, but you tend to get shortness of breath each time you think about something. You feel the palpitations, you tend to feel lightheaded. And this is in view of the many worries that you have. And you're affected so much that you call in sick, you stop attending crucial events, you tend to be absent from work here and there, and the worry does not go away so easily, like how I explained earlier, where you just forget about it once the event is over. Now, I do ask students, sometimes my younger students, and I say that when the O-levels and A-levels are over, I think now it's in the pipeline, it's going to be over soon. Some of them are already celebrating. I can hear their voice from their house. We're done. And then when I ask them, do you kind of forget the experience of preparing for O-levels and A-levels? Because this is like a whole year kind of jungle training, right? They go in and they're so stressed all the time. And they say, yeah, after a few days, I still feel it. I can't sleep properly because I keep thinking about my papers, the study routine. I can't get it out of my system. And it takes a few days. I think that's still okay because of the prolonged nature of the preparation. if I'm going to get 3-4 days of worry from this 1 hour session because I see the number of participants here is about 70 plus, and then it carries with me for 4-5 days, and I'm so afraid to run another webinar, might not be normal. Right? So that could be the onset of an anxiety disorder. You tend to have an apprehension about a future threat, although you can't really conceptualize what the threat is. However, you are able to articulate that I think this is happening, I think that is happening. So you tend to have a strong apprehension, very, very strong, deep-seated worry. It's both a psychological and physiological state. So that's why sometimes people get a bit confused. They thought they are unwell physically. And there's some physical symptoms that's making them worry and feel lightheaded and so on. And it involves the somatic, emotional, cognitive, and behavioral components. That's what makes anxiety disorder very complex. And sometimes people can't really pin down on what it is. Now, here are two issues, right? One, when you have the onset of this, it is not particularly dangerous, I would say. It's not like a life-threatening situation. But at the same time, because it's so complex, and you sometimes downplay the symptoms, this could also mean a delay in early intervention. And by the time you get to the tertiary institution, like a hospital or a clinic, sometimes it's a little bit too late. Right? But this is human nature. When something presents itself as a small little threat, we don't think too much about it. We may not want to go for early intervention. Right? I mean, let's face it, healthcare is not free here. It's not like if you feel like it, you go. I remember my national service days, this is like, 20 years ago. And if you go see a doctor when you are in the army, it's free because the Singapore Armed Forces cover it for you. So sometimes I will tell my friend, don't tell anybody. I say, hey, I think Friday, I can feel a bit of shoulder cramps, so might want to go see the doctor. And then my friend say, hey, don't bluff, people need you and all that. You go and take MC. I said, no, I think I really feel not so good. So Friday, I go and see the doctor, knowing that it's covered. And then the doctor asked me, how are you feeling and all that? And sometimes you need to use the right words. Doc, got a bit of shoulder strain starting to affect me, and I feel it's the onset of something, so really need your help because I think early intervention is good. Wow, easily get 1 day, 2 days MC. Please don't learn from this. My point is, early intervention is good, right? It's good primarily because not that you want a diagnosis, but just to ascertain and let the doctor assess you, or the psychiatrist to assess you, that your over worry is not particularly a problem. Right? This is something to consider because I feel that from what we know, by the time patients reach the clinic and the hospital, sometimes their condition is quite severe. When anxiety, this is a definition by the Institute of Mental Health under the Ministry of Health in Singapore, when anxiety debilitates a person's life in such a way that it interferes with day-to-day functions and relationships, professional help is definitely needed. So hopefully you get a sense of the difference between anxiety when it's normal and when it could be a disorder. Some news, anxiety in the news recently. What is this? Duke and US, COVID-19, 1 in 3 adults are anxious. This was early in the year, and depressed. Now, of course, when you read this, it's very surface, right? What do you mean by anxious? Do they have an anxiety disorder? If so, what do they have? And is this mild depression, major depression? What is it? Right? Clearly, the pandemic has given us some form of psychological distress, and people are at risk. So when you're at risk, you have to be a bit careful. You got more anxiety than usual. IMH, a recent IMH study points to a likely increase in mental health issues in Singapore amid COVID-19. Right? And this was in the middle of the year. Right? About 13% of 1,000 participants, so 13% here has reported symptoms of anxiety and depression. during the COVID-19 pandemic, but a heartening 81.8% said they would be willing to seek professional help for mental health issues relating to the virus. I don't know, Mr. 𝗟𝗶𝗸𝗲, the journalist here, whether that 81.8%, I need to really review it, because willingness to seek professional help for mental health is not as straightforward as seeking help for a cough. I would like to think that it's probably half, and I don't care if Straits Times is going to come for me. That's my own personal opinion. Not many people may be very comfortable to seek help because they're worried of being stigmatized. Poor students. Singapore students say parental and self-expectations. Right? If you're as young as me, you will know the acronym FOMO, F-O-M-O, fear of missing out, are sources of stress. Right? I don't know what these young kids are fearing of missing out. No, are they fear of me? I always tell my students, hey, you got FOMO, fear of missing out. I say, yeah, we are very worried, especially with social media. Let's say if you never study for my test, do you get FOMO also? Then look at me, are you trying to be funny? No, of course I'm not. Right? The FOMO, we must ask ourselves, what are they FOMO about? Fear of missing out what? And you can see how that impacts their academic performance. That's one. Two, I think parents are very concerned, which is good. Back then, I don't get a lot of attention from my parents. Teachers are the king. If teacher says A, parents will agree and say correct. You go home, you tell the teacher, you tell your parents, my teacher scold me. Very good, give one slap. Go back to school. Okay, teachers are the king. These days cannot. Teacher does that to you, lose the job. But parents have placed more expectations, and also the self-expectations of the child, because they have a sense that it's going to be a very competitive environment in future and they need to do very well. So all these things culminate together, and then the apprehension, that fear, that rising worry, that cumulative worries that you have will build up, and students get overly stressed. So it does affect a whole range of groups of people. It's not just an elderly condition. It's not an adult condition. It is also not a child condition. In fact, everyone can be susceptible to anxiety. Here's the DSM classification. Please don't get giddy after this. DSM-4, right? With the text revision, that's TR. And then now it's DSM-5. You can get a copy of this easily online. I don't know how many pages. You can go knock yourself out. Nobody reads the DSM-5, but it's useful if you want to pick out some of the criteria. Okay. So you can see from DSM-4 to DSM-5, there were some changes in terms of the classification. Specific phobia remains the same. Social phobia has now moved on to become classified as social anxiety disorder. You got panic disorder, now separated into panic disorder itself and agoraphobia. All these big mumbo-jumbo words I will explain to you very shortly. GAD stays the same, generalized anxiety disorder. OCD is now classified under obsessive compulsive and related disorder. So there are other disorders that may be associated with OCD. Right? And then acute stress disorder and PTSD comes under trauma and stressor related disorder. So essentially the DSM-5 is just a neater classification of the disorders. But you can see that the coverage for anxiety is quite a lot. Right? So there are many different types of anxiety disorders, and I wanted to highlight those that are covered in the DSM to you. Excuse me. There's specific phobia. This is where you fear certain objects or situation that is out of proportion to any real danger. Please don't underestimate this. I'm very sure you know of people who have specific phobia. It could be of heights, of water, spiders. There is a name, on the specific phobia of spider. Cockroaches, right? The flying ones, right? I know some of you will say that. Don't know if anybody got specific phobia of their partners or their spouses. No, cannot say that. I don't know whether that has a term for it. Phobia is not a worry, Phobia is a very strong sense of fear that grips you to a point where you take no explanation for it. Right? If someone tells you, hey, it's just a cockroach, it's not going to kill you. It's just something, it's just height. It goes up and it takes a roller coaster, it just go down, everything will be fine. You're heavily secured and strapped, nothing will happen to you. No, it doesn't work. This is a phobia where the fear has been with you for a long period of time. Later, we'll have a look at it. SAD, or social anxiety disorder, is the fear of unfamiliar people and social scrutiny. Right? I see this a lot in the field of education. Right? When I say a lot, I don't mean that it has to be 70% of my students, right? For me, one is one too many. And if I would say 1%, I do have some students who come and tell me, Anil, I have social anxiety disorder, I think, and I'm really fearful of how people judge me. And as such, I can't do the presentation. Please. And I'm like, okay, what do I do? Right? What do I do? So, of course, in schools, we do have some concerns over students who may have such a concern or issue, because it's very hard to say, don't be fearful. It's just a 3 minutes presentation. All you have to do is just stand there, look at the audience and think that they're all tomato heads and just present. Doesn't work. Panic disorder, I think it's a lot more serious. Anxiety about recurrent panic attacks. So you have experienced a panic attack and you get very anxious about them. Uncontrollable worry for a minimum of 3 months and more, that's a generalized anxiety disorder, right? And you have agoraphobia, which is anxiety about being in places where escaping or getting help would be difficult if anxiety symptoms occur. Maybe at this part, I can just do a very quick differentiation between agoraphobia and social anxiety disorder. If you look at social anxiety disorder, it's the fear of people in general and how they're going to scrutinize you and your behavior and your dressing and the way you speak. Agoraphobia is about your perception and interpretation of a place, a space, right? So you give meanings. I mean, a place is essentially a space with meanings, if you think about it. A space is just a space, but you put some things there, it gets meaning, it becomes a place. So they perceive the meanings in a way that contributes to their fear. So they size up a place and they say that, oh dear, if I get anxious, I don't know if I can get out of it. I find that this place makes it hard for me to escape or get help if I get my anxiety symptoms. So they start fearing places. But in social anxiety disorder, they fear almost everybody. Right. Hopefully that differentiates. I'll share with you the DSM criteria. You'll find it a bit technical. My aim is to get you to have an interest in a bit of it. Maybe you have a friend, a family member who might present some of these symptoms. You might want to find out a bit more. And I think a bit of psychoeducation is really useful, and at least you can then ascertain whether there's a need for early intervention. This is a little video. In the interest of time, a bit tricky for me to let all of us watch it, but I just want to share this on the meeting chat so that you can watch it at your own time. There are quite a lot of useful short little videos here, which I find helpful to also engage our young and our youth. So maybe you want to have a conversation with them about mental health issues. Do you really need to go to a hospital and clinic to do it? Maybe you can be the advocate. Maybe you can take matters into your own hands and speak to your child, your nephew, your nieces, and have an interaction with them. Anything that they see on the screen and engaging with some sounds, they like it. Kids are kids. Okay, yeah, maybe I'm generalizing too much. Those were the 5 anxiety disorders. Slight differences, but it covers most of it. Now, the DSM-5 criteria for specific phobia, perhaps. This is based on a marked and disproportionate fear consistently triggered by specific objects or situations, right? So you could have a phobia of an animal, an item, or a situation like heights and water in the big blue ocean, etc. The object of situation is avoided or else endured with intense anxiety. I think both are different types of poison. You avoid. When are you going to confront with it? So your life is going to get affected. You try not to avoid, you endure it with intense anxiety, that's going to freak you out as well, because the anxiety can sometimes have physical implications. What happens if you collapse and you really pass out? Could be more life-threatening in that sense. Symptoms must persist for at least 6 months. For social anxiety disorder, there is a marked and disproportionate fear consistently triggered by exposure to potential social scrutiny. See, if you don't experience this, it's very hard for you to understand when someone gets scrutinized, right? I mean, I've been going out and so on. So, in the bus, sometimes if people keep looking at me, I don't really feel fearful, but I do feel uncomfortable. And you know how, because I grew up in an era where if you look at somebody, and in Singapore context, it's like, hey, see what see, like see what see, that's horrible English, right? But what are you looking at? In Hokkien, there's a more rustic way of saying it. We get a bit uncomfortable, but we don't feel that we are scrutinized to a point where we get fear. You see, that's the difference. If a male starts looking at head to toe, you know how men look at women, look at head to toe, and women get uncomfortable. Like, why are you looking at me like that? The other way women look at guys head to toe, not quite often. I don't know, maybe there is. You do get a bit uncomfortable, but that's more in the context of modesty. It's not as if like, oh, why is this man or woman looking at me? And then the fear grips you, he's scrutinizing me and so on. Might be a bit, but you see, it's still a bit of a gray area. The exposure to the trigger leads to intense anxiety about being evaluated negatively. So much so that there's nobody evaluating you negatively. In fact, the person may be looking at you and say that, wow, you look well dressed, you look nice hair, nice face, whatever, nice shoes, walking very well, positive comments. But for you, it's negative. The trigger situations are often avoided or endured with intense anxiety as well, and must persist for at least 6 months. So please don't jump the gun in 6 days and go and call 999. Hey, police, I think I got anxiety. So how? Refer me or not? Can pick me up to go to hospital? No, cannot. Got to check. And I think the psychiatrist will also ask you the question, how long have you been feeling like that? Right. So if you say 2 months, 3 months, they'll probably monitor you for a bit. It really depends. I think I'm not coming from the point of view of a psychiatrist, so I'm not particularly clear how they do the clinical assessment. That is, for them to judge in the consultation room. Panic disorders, personally, I've come across a few people who have displayed some symptoms. I had several instances of seeing people was near fainting, but then we keep them calm and so on. So it was quite a frenzy, actually. This was in a public place. Recurrent, uncued panic attacks. So sudden, uncued, no prompt. You don't know when it's going to happen. At least 1 month of concern about the possibility of more attacks. You tend to worry and you stop going out because you feel that if I get an attack, no one's going to help me. I need to constantly be beside someone so that if I get an attack, I know this person may help me. So I need to feel safe. And can you imagine how different the life is going to be? Right? So this is a bit of a serious case here. There are quite a number of useful videos out there on panic attacks. I think the Institute of Mental Health have also recently developed some learning videos where their consultants create some of this awareness collaterals, let's call it, as part of their outreach. And this you can find online. Agoraphobia, disproportionate and marked fear of anxiety about at least 2 situations where it would be difficult to escape or receive help in the event that you get some panic. So if you are sharp enough, you realize that some people can have 2 of these disorders occurring together. We call this comorbidity. So for example, being outside of the home alone, that is scary enough for them. Traveling on public transportation, feeling that you can't escape. But I'm not trying to trivialize this, but I think the only time I get really scared on a public transport where I can't escape is you are on the expressway and you have a stomachache now, where to go? You can't tell the driver stop suddenly, you see, but I'm just trying to show you that in those instances, you get anxious because of a tummy ache, but it's not an unfounded fear, you see. That fear that you can't get out of the bus is now linked to another health hazard, which is you need to go, nature call. So we need to establish, I think, the context. Even open spaces such as parking lots, marketplaces, being in shops, theaters, cinemas, standing in line, or even being in a crowd. Being in a crowd is very common, and they don't like it. They don't like the idea. They feel that there is something bad that's going to happen. So hopefully, the DSM criteria for these 5 helps you to differentiate clearly now the difference between normal anxiety and anxiety where it's a disorder. These situations typically consistently provoke fear of anxiety. So you start avoiding, and 2 situations become 4 situations, become 8 situations, 16, and cumulatively it increases. Sooner or later, got nowhere to go. So where do you go? Online, cyberspace. But what if cyberspace give you anxiety too? That's the end. Very interestingly, I'm quite, I need to find time to do this. I want to find out whether people get anxious while they're on cyberspace. I think there are some studies that's being done on it. I need to go and look at it because the online space, or what we call cyberspace, is also a space in itself, and people attribute meanings to cyberspace. So you can get anxious from using too much social media. I'm sure you all have heard of it. And oftentimes the situations are avoided, and this is a common criteria across most of the anxiety disorders. Symptoms to persist for at least 6 months. So all this, I've not written it myself, I've taken it from the DSM. Other key findings, I mentioned comorbidity. So this is the overlapping of symptoms. Overlapping of symptoms earlier, like, some things that's present in social anxiety disorder is also present in, say, general anxiety disorder. You could have comorbidity, and I think this is where my experience came in. I realized that a lot of the substance abusers that I dealt with tend to also have high anxiety, right? And they cannot cope with their anxiety, and so they turn back to their substances. It is really a vicious and, pardon the language, shitty cycle because they can't seem to get out of it. It's very tough, right? Severe anxiety can later morph into depression, and that's a more serious mental health disorder, and other kinds of problems like personality disorders. You could also be affected physiologically, and you could develop a medical problem. Right? So someone with a medical problem can have bouts of anxiety. Right? For instance, fearful that the back will give way, the knee will not work because of the pain, and so on. So comorbidity is very common among anxiety disorders. Some risk factors, well, we can never discount the genetic or heritability factors, but please take note that we always have this thing called a gene environment interaction. So it's not nature versus nurture, it's nature and nurture. And we need to try to understand. Neurobiological factors refers to all the activities that go on in the brain, high or low functioning of serotonin, different types of neurotransmitters. Those overactivity in your brain could present an explanation to why some people tend to get more anxious than others. Social factors, negative life events, job loss, or maybe the threat of losing your job is enough. I think that is already quite a headache. You don't have to wait for your job to be lost. Having to deal with the consistent threat of whether you'll lose your job, whether your contract will be renewed, I think that's enough to stress you out. End of relationship, death of loved ones, etc. Many different types of social factors that can come in. And different people have different levels of resilience of processing information. So please don't go and tell someone who's anxious that, hey, it's end your relationship, don't worry, it's not the end of the world. It's not the only tree in the forest. It's not the only fish in the ocean. Gosh. All these individuals need to go for psychological first aid. That's another course that I'm dealing with, a workshop. There are certain things that you should say and you should not say. Right? Do not trivialize something that someone is experiencing because it could be a big deal for them. Cognitively, how you marshal your thoughts, right? Whether you are able to convert the negative beliefs to positive ones, the amount of control you think you have over your environment, and the heightened attention to threat. All these things can determine how you deal with anxiety. The more positive it is, you have lower risk factors. The more negative, higher risk factor. You know, and this guy here called the mind is so sophisticated that sometimes it gets very difficult to control the mind. Treatment, you may be interested. What do we do? Psychological treatments emphasize exposure. Face the situation or object that triggers anxiety. I can't be sure, but I was told that since I was young, I was quite afraid to participate in activities that involves height. For example, cable car. And I realized that this carried on with me for a while. Not that if I walk on a HDB and I look down, I get really scared. No, but the act of doing something where it's from height. So maybe diving, or, you know, I went for this corporate training in Sentosa where you have all the harness and thing and you jump. And I was the first one to go because these buggers like to go by alphabetical order. Then my name is A. They say, Anil, you're the first to go. I'm like, what kind of sorcery is this? Can you let someone else go first? No. Faster, you go first and we'll take the cue from you. My God, I was shitting in my pants standing up there, knees wobbly. And this is the first time I realized that your knee can wobble. Of course, I took the plunge, but I think that was after 15 minutes of pep talk. I was talking to that person. I was like, hey, what happens if something goes wrong? All this end of life conversation came up. I was scared. But once I went and confront the fear, I actually thought maybe I could go up and do one more time, but maybe next time. And I felt that a little bit of the fear dissipated. I don't know how to explain, but it went off. Now, exposure may not be the best for everybody because you could end up triggering their anxiety in a wrong way. So you got to be very careful. It needs to be done by a therapist. Systematic desensitization would be better. You use images, so imagery, and also ensure that there is some relaxation aspect. So maybe in a room with quiet music, lavender smell or chamomile or whatever you have, expose them to some images. They might feel triggered a little bit, calm them down, talk to them, be gentle. Some level of relaxation plus exposure in a systematic desensitized way would help. So they don't actually face the object. You go through systematic desensitization and then you try the exposure. cognitive approaches typically in therapy where you try to change their beliefs to help them to cope. So you challenge their expectations and their unfounded beliefs. Might be a bit difficult, but helpful, right? Because some people are not the gung-hos. They don't want the actual, give me in a room full of cockroaches flying around. Hey, you think what? This one Guinness Book of Records. So go and see how long you are standing there. The guy will die. He will faint. You put him in a room of cockroaches, but maybe talk to him or her about cockroaches. Change a bit, and then maybe watch a little video and so on. Do it slowly. I think anxiety needs to be quelled slowly. It can't happen like that. CBT works on both cognition and then give you homework, right? So get you to go and try the exposure. So if you look at CBT, right, it's a bit of a reverse. You work on the cognitive approach and then you try the exposure and the systematic desensitization, step by step. Can't do everything at one go. You got medication, of course, for more serious cases, and anxiolytics, benzos, antidepressants. Not supposed to be a comma there, it's supposed to be a close bracket. And then you got D-cycloserine, DCS, enhances learning during exposure treatment. This is something that's, I think it's fairly new, right? Where you get people to go for exposure treatment, and then you also kind of give them the information that they require. You give them space to question what they're going through, and hopefully they take a more of a learning stance towards it, not simply because of just being exposure to try to get rid of it, right? So then slowly they will be able to extinct their fear, right? So it takes time. And of course, DCS is more of like a compound where they use for treatment. So it's a partial, if I'm reading something here, agonist at the glycine recognition site. Okay, so some receptor stuff that they give you, and that helps you to process the information during the exposure treatment better. With regards to how fast you get treated, it really depends. Different people react different to treatment. Different people react to different treatment methods and procedures. So I think it's down to the individual. Okay. I've spoken to my colleague Chloe from Ventis. I've already shared this e-copy of the book. That's not my girlfriend or my wife, but that's just a cover picture of the book. Abnormal Psychology by Susan Krauss-Whitburn, and this is, I believe, 2019 or 2020, should be 2020. It gives you the clinical perspectives on psychological disorders, and I particularly like how they do it because it's the picture. It's not a face of someone who is typical. You go in Google, right? You put anxiety. You know what picture come out first? The fellow hold the head like as if he lost the lottery, lah. Right? We don't want those kind of imagery. We want something that is more open, that gives us a sense that this is knowledge that we can embrace and we can find out more.